So my name is Robert Skov. I'm the current president of ESCMID and a clinical microbiologist by training and working out of State and Serum Institute in Copenhagen at my normal life. It is really a great pleasure to welcome all of you here to the third edition of the ESCMID Global Leaders Group for AMRs, our joint session, the Science Policy Forum. We started this forum 3 years ago in Copenhagen in acknowledgement that if we really want to make progress here, we need to bring scientists and policymakers together. I think that was a learning coming all the way from the HIV pandemic, that if you really want something to happen, you really need to get the different stakeholders in the same room. So the overall goal with these science policy forums is to have an integration of science and policies, bringing scientists within infectious diseases, clinical microbiology, veterinarians, One Health, behavioral science, economical science, all the different scientists, bringing them together with the policymakers to foster the crosstalk between them. It is to get scientists to think policy, to integrate the policy into their world, but also to inform the policymakers on what is the important gaps that they see at the moment. On the other hand, is to bring in the policymakers to think science. What are the knowledge that is needed for them in order to to define and implement the target set, but also to provide the questions that they need to have convincing evidence to actually implement these things. Post-UNGA, it is very important that we are keeping momentum and that we provide the evidence needed to obtain the bold targets that were set for the human space. I will just pause a second when I say human space, because I think we actually lacked targets in some of the other spaces, but I think we're going to discuss this today. We also need to have the tools for implementing the actions needed to mitigate the AMR in itself, but also the consequences of AMR. And one of the important things, I think, is to push for getting the independent science panel for AMR really established to inform the policymakers as an independent group that can really give independent policy advice. Today, we will move this forward with two very interesting sessions that will look at the situation here post-UNGA. And it is my great pleasure to introduce the Director General, Dr. Tedros Ghebreyesus, for his introductory remarks, which we will have as a video call. So, can you please start the video?
Dear members of the Global Leaders Group, dear colleagues and friends, I thank the European Society of Clinical Microbiology and Infectious Diseases for co-organizing this event, and Prime Minister Motley for her leadership. Antimicrobial resistance is where research and action come together. The only way to stop this fast-moving threat is to implement interventions based on the latest data and research. AMR evolves rapidly, and outdated policies can worsen the problem. Policymakers need the best information to implement the best interventions, such as antibiotic stewardship programs, containment in water ecosystems, or restrictions on antimicrobial use in agriculture. At the same time, we must strike a balance between innovation and regulation. Scientific advancements, such as new antibiotics, alternative therapies, and rapid diagnostics, need to be incentivized without encouraging overuse. At the UN General Assembly last year, world leaders set new targets for combating AMR. To support countries to achieve those targets, WHO and our partners in the quadripartite are updating the Global Action Plan and establishing the Independent Panel for Evidence for Action Against AMR. In a world of constrained resources for health, thank you all for your continued commitment to stopping the spread of AMR, saving lives, and building a healthier and safer future. I thank you.
I think having Dr. Tedros here speaking to us is a significance on the importance of this event here. And I now see coming into the scene Lothar Wieler, who will do, Professor Lothar Wieler from the Global Leaders Group, who will also have the possibility to give a few introductory remarks before we start the conference. So very welcome, Lothar.
Just in time, sorry. So I'm speaking to you today as representative of the Global Leaders Group on AMR and One Health. Good afternoon. I'm very pleased to welcome you to this year's AMR Science Policy Forum during this ESCMID Global. I sincerely thank everyone at ESCMID for the collaboration with the Global Leaders Group on AMR and the quadripartite Joint Secretariat to make this event possible. The Global Leaders Group on AMR actually is comprised of politicians, scientists, and policymakers, reflecting the critical need for strong collaboration between policymakers and scientists in the response to a threat like the antimicrobial resistance. Me, as a scientist, I'm really glad being part of this endeavor. Today's forum aims to further strengthen links between our work to fight AMR at the political level and your vital efforts in the scientific community. Last September, the UN General Assembly endorsed a strong political declaration on AMR that sets out new targets and the actions that are essential at the global level and in every country. And actually, I was thrilled to experience the supportive political commitment from each and every country at that meeting. This year's forum as ESCMID Global provides an important opportunity to discuss what we must do in practical terms to reach those targets and how we can translate the political declaration into action that will mitigate the threats posed by AMR across human and animal health, agriculture, and the environment. That's the quadripartite action, and that's important to understand. Well, our work as scientists is vital in so many ways, not only at this unprecedented times, but always and in general. First, most importantly, we have to identify best practices for infectious prevention, antibiotic stewardship, and clinical care. Actually, together with colleagues from the Robert Koch Institute, we just have submitted a global analysis on national action plans. And again, one outcome was the infection prevention and antibiotic stewardship. These are the two most important and efficient pillars of reducing AMR. Second, to better understand the routes of transmission of AMR in humans, animals, and agriculture system, and through wastewater and industrial pollution. Third, to improve AMR surveillance systems, including through genomic sequencing, real-time monitoring, but also applying more sophisticated, innovative tools, which are AI-driven data analysis-based. And that's a future challenge that us as scientists we have to take. Also to develop new antibiotics and alternatives to them, as well as affordable point-of-care diagnostics and vaccines. Again, also, when you look at the development of new antibiotics, AI-driven solutions really pave new waves and avenues. Personally, I think as scientists, we should also strongly support the work of the quadripartite organizations, especially in the process of establishing the independent panel on evidence for action on AMR and updating the global action plan on AMR, which we will hear about in later sessions. In turn, it is incumbent on policymakers to ensure that AMR is global and a national priority, and that the response is well coordinated and funded, and that this is under threat. I don't have to tell anybody in that room currently. Also, they should put in place policies and regulations that accelerate innovation access and ensure that antimicrobials are used as responsible as possible, and to build capacity and infrastructure where it is most needed, particularly in the low and middle income countries. This whole global health finance mechanism currently is under threat, and therefore countries out of the US have to take more duties here. The 2024 political declaration will only be a watershed in the response to AMR if we work and act together in common cause. I'm sure that this year's Science Policy Forum will further embody that essential spirit of collaboration. I thank you for your continued efforts to help stem the rising tide of AMR, and I wish all of us a very productive afternoon. Thank you.
Thank you very much. And with no further ado, I think we will move now to the first session here, which will be chaired by Holger Rode and co-chaired still with Professor Chukwu, who will be online. So please, Holger.
So, good afternoon, ladies and gentlemen, dear colleagues. I first would like to hand over the mic to my co-chair, Professor Chukwu, who will give some introductory words to this specific session. Please go ahead.
Thank you very much, Holger. And I want to join the Director General of the WHO in welcoming everyone, every participant, to this very important session, which deals with moving from commitments to action of the UNGA Political Declaration on Antimicrobial Resistance. I am a member of the Global Leaders Group on Antimicrobial Resistance. And of course, that now means we work hand in hand with the quadripartite secretariat that has been involved in moving forward the agenda to eliminate AMR. The DG of the WHO, as well as Professor Lothar Wieler, both of them have basically outlined what the business of this session is all about. The Global Leaders Group, since 2020, when it was inaugurated, has been working quite hard under the leadership of the Prime Minister of Barbados for advocacy, for mobilization of thoughts, for coordination of thoughts, and for coordination of plans, all aimed towards ensuring that is silent pandemic, that is very, very silent. It's not like coronavirus, nor is it like Ebola virus disease, but that mortality could be reduced, and targets have been set by the Global Leaders Group. Fortunately, working along with all stakeholders, the Global Leaders Group, as well as the quadripartite secretariat, and all the key United Nations agencies involved in this campaign, have worked hard in negotiating with all the member states of the United Nations. And in September last year, 2024, we were able to get the commitments, the political commitments from all the members of the United Nations on how those targets will be made. There are key targets on mortality. We're talking about 10%, reduction of mortality, by the year 2030. We are looking at ensuring that One Health Action Plan is keyed into by all stakeholders. We are looking at ensuring that at least 60% of the antibiotics classified as accessed by the WHO are accessible, very financially accessible, physically accessible to all that will need it globally. We're also looking at how we can drive down the inappropriate use of antibiotics in both in the plant and animal sectors. So this afternoon, we have a distinguished panel of speakers that will take us through these various targets, key targets that have been set in the United Nations General Assembly document. We are going to hear them tell us how we can ensure that they are not only achieved, but they are achieved through evidence-based information and data. Without evidence, we'll be groping in the dark, and most of the actions will be taken will be more like throwing the dice. But with evidence, and GSG, working with the quadripartite secretariat, is currently working on ensuring that the panel on ensuring that we have evidence-driven policies will be set up sooner than later. That way would ensure that whatever policies, whatever actions, particularly through the national action plans, will eventually lead us to those things that will make us ensure that we achieve these global targets. Finally, of course, we need money. So finance is important, and the targets for finance will need to be met. So on this note, I would like to hand over to Holger, my co-chair, and I also ask Holger to go ahead and introduce the first speaker. Thank you very much.
Thank you very much. With further ado, I would like to call Professor Joe Lunard to the stage to give the first presentation. Professor Lunard is Professor of Epidemiology at the University of California in Berkeley, and the title of his talk is The Overall Impact of Currently Known AMR Interventions. We're very much looking forward to your talk. Thank you very much.
So to begin, we start from a standpoint of some recent attempts to measure the burden of antimicrobial resistance globally that suggest knowing what the syndromes that are associated with the greatest burden of mortality are and what pathogens account for the greatest number of deaths associated with or due to resistance. We start with the standpoint of being able to assess what potential interventions might be able to do in achieving reductions in preventable deaths. So as of 2019, it was estimated by the Institute for Health Metrics and Evaluation that globally there are about 7.7 million deaths due to bacterial infections, of which nearly 5 million harbor antimicrobial resistance, and about 1.27 million occur simply because antibiotics are not effective in resolving these infections. So of this burden of 7.7 million bacterial disease deaths, about 1.27 million are believed to be attributable to a lack of effective treatments due to antimicrobial resistance. We set out earlier to estimate of this burden how many deaths could be programmatically preventable by achieving existing targets in the implementation of various interventions. These include interventions targeted at healthcare settings where there are existing commitments to improve the implementation of infection prevention and control measures that could reduce the acquisition of resistant infections in healthcare environments. In addition, interventions that have already been made as commitments for reducing the reliance on unimproved and unsafe water, sanitation, and hygiene facilities. And last, implementation of pediatric vaccines that have the potential both to directly prevent resistant infections associated with bacteria and to reduce the incidence of infections that precipitate antimicrobial treatment and thus propagate selective pressure. And so as part of a large-scale series of papers addressing the preventable burden of antimicrobial resistance and setting targets, we aimed to assess what the burden that could be preventable would be associated with delivering on these existing commitments. So the first of these I'll summarize briefly concerns infection prevention in healthcare settings. There is globally a disparity in access to healthcare environments where infection prevention and control measures are adhered to, with the poorest settings, those with the lowest GDP per capita, illustrated in the bottom here, having the lowest compliance as well, or the lowest ability to comply with achieving targets for universal delivery of care that meets current standards seen in higher income settings. There is also evidence that improving infection prevention and control delivery in healthcare environments reduces the risk of bacterial nosocomial infections. So modeling the potential outcome of resolving these gaps in infection prevention and control implementation in low, lower middle, and upper middle income countries, we estimate that up to 337,000 annual deaths associated with antimicrobial resistance could be prevented. And this reflects current estimates that suggest a very substantial volume of all AMR-associated deaths are acquired in healthcare facilities in low and middle income countries as well as in high income countries. Next, looking at committing to and meeting existing targets for delivering higher quality water, sanitation, and hygiene infrastructure, there are prevailing estimates that suggest a substantial proportion of not only diarrheal, but also other infections can be prevented when communities have access to the highest quality wash or water, sanitation, and hygiene facilities, meeting the standards that we know and expect in high-income countries. Although there's been unfortunate results of some recent trials delivering lower quality wash interventions globally, there is reason to still commit to delivering the highest quality available water and sanitation and hygiene
camera, please?
Interventions in order to resolve these remaining access gaps. And we estimate accounting for both the prevention directly of resistant infections and through reductions in the incidence of infections that precipitate antibiotic use, that about 183,000 deaths associated with AMR infections could be prevented annually by meeting existing Sustainable Development Goal targets for universal access to high-quality wash facilities. Speaking next about vaccine interventions, we can first consider the potential impact of vaccines that are either already in use but not yet delivered fully to meet every single child in low and lower middle income countries as well as upper middle income countries, as well as vaccines that are now coming online, such as typhoid conjugate vaccine and in the very near future likely group B streptococcal vaccines. So when we consider the direct impacts of these vaccines on AMR infections, we estimate that about 95,000 deaths associated with AMR could be prevented each year. But a large part of the impact of vaccines also concerns our opportunity to reduce antibiotic use in the community through the prevention of infections. There is widespread evidence that we reviewed of ecological relationships between antibiotic use and antimicrobial resistance, with settings that experience higher rates of antibiotic use, experiencing as well greater selective pressure and a higher proportion of infections that are resistant to available antibiotics. And so accounting for this dimension of the effect of WASH and vaccine interventions, we estimate that there is substantial additional mortality that could be prevented simply by reducing selective pressure that causes antimicrobial resistance to be present and to persist in various settings. So this adds substantially to the avertable burden of disease, and additionally suggests that there is priority associated with viral vaccines as well as those that target AMR pathogens directly. Things like RSV, rotavirus, and influenza, although they are viral pathogens, contribute substantially to antibiotic use in the community, and vaccines against them may have substantial role to play in reducing antimicrobial resistance for that reason. So, accounting collectively for these effects of well-documented interventions that have been assessed in robust frameworks, we can say that 10% reductions in AMR burden are directly achievable and readily achievable under existing commitments that have been made for countries to improve the delivery of infection prevention and control, of WASH infrastructure, and of vaccines by the year 2030. There are other interventions that have been discussed in the lead up to this session and in the lead up to my talk that we did not assess and where intervention assessments have not necessarily been as widespread or robust, and where there is still room for further evaluation and further inquiry into their potential effectiveness. But considering these three dimensions of intervention where commitments already exist, there's clear evidence that a 10% reduction in mortality in lower middle, and upper middle income settings is readily achievable and should be met by 2030. Thank you.
So before we go into the discussion of this presentation, I would like to ask the next presenter to prepare. The next presenter will be Ivan Hutin, the Director of the Department of Universal Health Coverage, Communicable Diseases at the WHO Regional Office for Eastern Mediterranean. Unfortunately, Professor Hutin was unable to join today on site, but he will give his presentation online, and we are very much looking forward to hearing his presentation with the title Reducing AMR-related Mortality, Monitoring and Achieving the 10% Reduction by 2030. Thank you very much.
Thank you so much. And I'm sorry, maybe my affiliation is a bit outdated because for the last 12 months, I've actually been director of the Department of Surveillance, Prevention and Control of within the AMR division in WHO headquarters. So in these few minutes, I would like to provide you with an overview of how we can achieve the 10% reduction in mortality by 2030 and monitor that. So the overall goal that we have been given by the political declaration is to reduce AMR-associated mortality by 10% by 2030. Now, the baseline that is actually quoted in the political declaration is based on the GRAM, Global Burden of Disease IHME study, with the initial estimates from 2019. So that is, of course, is a mathematical model. We need to keep that into account. So to achieve this goal, in 2024, also, the World Health Assembly has endorsed 4 strategic priorities for our member state to lead the work in the health sector and make sure that we get there. These 4 strategic priority call for a person-centered approach, which is essentially a PHC for UHC approach to addressing AMR. So given that we really want to back construct the program on the basis of what we want to achieve in terms of mortality reduction, what we're trying to use is what we call the result-based management approach. So we want to achieve impact on morbidity and mortality. Therefore, we will want to reduce the prevalence of resistance and reduce the frequency of use of antimicrobial. So for this to happen, we will have to increase the coverage of prevention, diagnosis, and treatment intervention within UHC. And for that, we want to have AMR that is mainstream in health planning and financing, and also, of course, beyond the health sector. And for this to happen, we will need political will, investment, and a One Health approach. So how do we achieve the progress, and how do we document this progress? So at WHO, we've been working with the quadripartite organization to host this monitoring system called tracks, which keep tracks mostly of the structural indicator and the input indicator, the resources that are being invested. But beyond that, we have also a program including prevention like WASH, IPC, and immunization that have a number of coverage indicators, which we are all consolidating within these country profiles so that we can see how we're improving in terms of coverage of these interventions towards the progress. And of course, within the AMR division, we keep track of the important outcomes, such as the prevalence of resistance with glass AMR and the frequency of use of antimicrobial with glass AMU. But so far, we're talking about things that go all the way to outcome without addressing mortality and morbidity. As we saw, the impact, as proposed by the political declaration, go all the way to mortality and morbidity and mortality. So what do we need to measure mortality and morbidity? It's not easy. It requires vital registration system. It requires monitoring antimicrobial resistance. It requires work in healthcare facility, vital registration. And it's about a whole system we need that cannot be set up immediately in all countries, but for collection of information, analysis of this information, the use of this information to plan the evaluation of the quality in some sort of data quality cycle for these burden of data. So there's a number of studies that are ongoing. There's a number of projects in vital registration, but this is only partial information. So because this is partial information, we need to infer and make more generalizable estimates, which are being done with mathematical model. But the mathematical model, they don't live in zero gravity. They need to be connected with this empirical data, and there needs to be a dialogue by which, of course, the product of our data system can be used as input indicator, and the output of the model can be also compared with empirical data with some validation comparison. So as you see, we're getting to a comprehensive data system that is rooted in the need to have impact on mortality and morbidity, but that goes back all the result chain. So overall, the way forward to achieve and document the impact on mortality is through what we propose as a global AMR data collaborative that we are facilitating at WHO. So knowing, of course, that we hope that the country will be going forward with the implementation of the 4 strategic priority, in terms of the documentation, the foundation will be an accountability along the result chain to make sure that we get the right structure, the political will, the PHC for UHC approach, the increase of coverage of intervention, the reduction of use of antimicrobial resistance and the reduction in resistance. Then the second leg is data collection and sharing, including with these data portals that we have on data.who.int, so that member states can see their performance and other performance, and we have this comparisons across countries and regions. And on the top of this come validated burden of disease models that are connected to the rest of this data, so that they are credible, and so that ultimately we can be confident that the progress that we do on all of these indicators is also associated with the progress in terms of mortality reduction. So thank you very much for your attention, and I'd like to say that we think of this global AMR data collaborative as something very comprehensive. We will be starting with the work on burden, which is the first priority and the most difficult aspect, but we see it as comprehensive and then involving the data all along the result chain. Thank you very much.
Thank you very much. And we move along to the next target and hear the insights of Professor Michael Charland on assessing the 70% reduction target, giving his title the Global Antibiotic Policy, Achieving the Global 70% Access Target. Mike, thank you very much.
Thank you very much indeed, Holger, and I'm delighted to talk today about the AWARE system and the 70% access target, which are two of my most favorite things to talk about. So this is a great day for it as well. I think it's also the UNGA declaration, I think, when we look back, will be seen as a strategic shift where we suddenly started to recognize one of the key scientific questions in AMR, which is how do we achieve and derive sustainable levels of global antibiotic use and national antibiotic use, and how can we then achieve those sustainable levels of use that allow population health to be treated, but without pushing resistance ever higher. And so that's the key question that we're looking. The UNGA Declaration had two parts. So the first part was really to recommend that as countries move forward, they use the WHO AWARE system. WHO should be congratulated on that, because since the G7, G20 and G77 and now the UN General Assembly have adopted the AWARE system, since its origin in 2017, that's really remarkable progress that has been taken forward. So we now have a standard methodology for antibiotic surveillance, use surveillance, and then policy interventions and target development. The second was to expand the previous World Health Assembly recommendation at a country level that 60% of antibiotics should be access use. These are narrow spectrum antibiotics predominantly used in the primary care setting, amoxicillin, for example, and that should now at a global level that 70% of all antibiotic use used in humans should be access antibiotics. So where are we now? Well, we started off with the first dose of penicillin, of course, on the 12th of February 1941, as you recall. And today we're using around 50 billion doses of antibiotics annually. And the WHO AWARE system is based on the Essential Medicines List. And the Essential Medicines List provides the list of essential antibiotics that should be available across the health settings. And there are 41 antibiotics on that list, 20 access, 12 watch, and 9 reserve. It should be noted that, of course, actually the WHO have now given an AWARE group to antibiotics that are trying to work for all antibiotics that are used in humans. And that's over 250 antibiotics that have been identified so far being used in humans. And of course, that number continues to rise. And the AWARE system is now developed from being an AWARE categorization list to a guidance book giving infections for treatment on 35 infections, and now AWARE quality indicators, quantity metrics, education, and it's now developing into a whole program of its own. On understanding antibiotic use in humans, we have to recognize that antibiotics in hospitals are, of course, critically important, but in fact a relatively small part of the overall total antibiotic use, and 90% of all antibiotic use is oral in the primary care health center and 10% in hospital. With my thanks to the GLASS AMU team, then the global levels at the moment for the 60 countries, territories and areas that report to GLASS currently, then we're actually reaching about 53% or so of access antibiotics, 45% to watch, 1.7% not recommended, and 0.3% is reserved. We need to recognize that actually new antibiotics, particularly against carbapenem resistance, are actually currently still a disappointingly small amount of global antibiotic use, somewhere around about 0.1% overall. Unlike the new antibiotic market, the generic antibiotic market is not broken, actually. It's around 40 to 50 billion US dollars per year and is rising steadily at about 4 to 5% of growth each year, and has done all the way through. So antibiotic growth has been persistent and continuous. And recent health economic analysis, I'm pleased to have a look at some posters here from the Adilla project, funded by Wellcome Trust, shows that really is very significant cost savings as countries move across to a more access antibiotics, because broadly, particularly in primary care, access antibiotics are about half the price of watch antibiotics. So to end, really, I think, how do we think about implementing the progress that we're discussing, following on Ivan's importance? We really need to think now about not only antibiotic stewardship, but antibiotic policy. Broadly, stewardship is an individual patient level intervention or hospital intervention, but antibiotic policy is really thinking about the population as a whole, an exposure of antibiotics across the population. Some of those instruments will be financial instruments or targets, and a range of interventions will need to be taken forward. As Professor Houghton was talking about, we need to really substantially increase the amount of antibiotic monitoring, markedly enhance the role of GLASS AMU, and start to think really about a whole lot of existing data sources already out there that aren't being properly captured, which includes data sources about warehousing and procurement and a whole range of other data sources. This will need complex analyses to start to integrate these data sources and embedding the sort of the models into real-world data. And we also not only need to think about relative about the percentages of antibiotic use, but also the total levels of antibiotic use. So start to measure actually antibiotic use in both ways as well. And that, I think, leads us into the policy and understanding, getting much better national assessments of antibiotic use, learning from IPCC and other areas where we start to think about assessment reports, which will get a much better, more robust exposure for antibiotic use that would allow governments to be more clear about their policy interventions and be more sure about their policy interventions. And I think this monitoring, analysis, and policy, we're developing now aware maps, I think, of how we should be moving the forward. We do need to have much clarity about the relative cost effectiveness about direct interventions, and as Joe was talking about, indirect interventions, and actually get some comparative cost effectiveness that will help to inform country level. And of course, we must ensure, of course, as this we're discussing, universal access to the most essential, the key essential antibiotics as a core component of this, and that needs to be significantly enhanced. We're delighted that across the One Health perspective, the development of VetAware, sort of led by Well after the Jeddah Declaration, is great, and I think that will enhance wide engagement, including for manufacturers, and we need to be bringing manufacturers into our dialogue and our debate, not only for across the IPA, but also across Generic Manufacturers Association. I think that this UNGA has now led to an increasing understanding that AMR and because AMU really is thinking about this in a medicines management way, a medicine management policy, and really beginning to integrate with medicines management teams at countries and national levels and sort of integrate and bring them in to do that. And in the long run, what we need to do, of course, is define the optimal levels of the sustainable antibiotic use that are based on population need, so that actually they reflect population burden, as Joe was talking about, and actually antibiotic use begins to reflect those. And this, I think, is going to be future work of the panel. Thank you very much.
Thank you very much, Mike. And it is a great pleasure for me to call the next speaker to the podium, Professor Chantal Morel. She will give us a slight different angle of view, diving into the economics of the AMR crisis. Chantal Morel, she's a health economist at the Antimicrobial Resistance at the KPM Center for Public Management at the University of Bern, and her title of her talk is Achieving Meaningful Progress on AMR Through Better Metrics in Clinical and Economic Analysis. Please go ahead.
Thanks, Holger. I'm just going to talk a little bit about the space between research and implementation of national action plans in country. Now, as we know, many countries are not yet funding the implementation of their national action plans. The latest track survey by WHO says around 10% of countries worldwide are actually implementing their plans. Now, many of these countries have had their plans in place for 5 years or so. So there's something that's not happening. Now, resources are being made available, but still we're not seeing a lot of progress on this front. Now, I would argue that perhaps we have a problem with the way we are framing AMR. Bacterial AMR has a real disconnect with the way countries are seeing things. So first, of course, they're disconnected from clinical impact. You could have all the resistance genes in the world, but they may not be expressed, so they may not have any real clinical relevance. There's also a disconnect when it comes to the diseases that leaders see their people dying from. They see them dying from parasitic infections. They see them dying from viral infections. We don't really have the data to show that they're dying from bacterial infections. So then when we come with demands to implement a national action plan, to find funding for it, to put the time, the effort into it, it becomes quite a big ask. Also, there's a disconnect from the local reality when it comes to access. So of course, especially around mortality, right? You could have a patient that has an infection that's susceptible to all drugs that are on the market. But if they don't have access to any of those drugs, then in terms of treatability, it's the same as having a pan-resistant infection. Also, when we talk about implementation, we are still maintaining the jargon and the framing of AMR from research. We basically take it out of its health systems connection, and we talk about it in a way as if the measures can be implemented vertically, completely separate from the health system. And for leaders who are trying to make decisions to implement their national action plans, that's really confusing. Now, also in terms of motivating the implementation of these plans, often we ask economists to look at what the cost effectiveness is for a national action plan, or what's the investment case for tackling AMR. But we have a bit of a problem here, because when we try to do so, the measures that we're talking about, so whether we're talking about WASH or surveillance or IPC, we have to cost the whole intervention. We can't take it apart. We have to cost the whole thing. But then in terms of the benefits, we're only capturing a very small portion of those benefits. And the result is that we are massively penalizing AMR-related measures. So if you're talking about a relative cost-effectiveness study, then you're basically penalizing whichever ones are most costly, or for whom we have the least amount of effectiveness data. Or you could be talking about the whole NAP plan that could come across as being very cost ineffective because of this fact that we are looking at the benefits in a very, very narrow way, when in fact they apply to all infectious diseases, pretty much. So I say, well, okay, we're moving really slowly right now, but clearly, we've kind of messed up in how we've conceptualized these things, and we've made it really confusing for implementation. We cannot use the same language from research that is very much focused around the microbe and microbiology to then extend to implementation, where really you're talking about health systems. Now, I see targets. I'm glad now we're going to be talking about targets. We're talking about targets here. This could be an opportunity to reframe the way we are seeing AMR, and to perhaps try to make these things more connected and remove some of this confusion. So perhaps we could be looking more formally at what we actually mean, what we keep implying but we're not really saying. We're talking about the treatability of infection. everyone understands treatability. Whether you're in the research world or outside the research world, you get it. It's also universally applicable. We could be talking about settings with very high levels of access and settings that have poor access. We're talking about treatability. It's one single measure. It's actionable. It's easier to track. Now, is it okay if treatability also then has to take into account non-bacterial infections? Yes. Most interventions that we're talking about, whether it be supply chain strengthening, whether it be WASH, whether it be IPC, most of it applies to all of these. So in many ways, there's no reason to keep singling out bacterial infection, other than within research and within perhaps small areas, perhaps as modules within stewardship and certain hospital-based IPC. Now, from an economic perspective, the economic burden comes from the fact that we're altering treatability. It does not come from resistance itself. So it also makes, there's an argument here also from an economic perspective to be looking more formally at treatability rather than AMR per se. Also, now there's the issue of just getting us going in terms of implementing our plans. We want all stakeholders to be moving in the same direction, trying to tackle the same thing. And we need to be a little bit careful, because when we focus on AMR, we actually sometimes work against access, right? If you introduce a drug somewhere where it hasn't been used before, you will be increasing resistance to that drug, of course. But we cannot allow that to become a pretext to not improve access. Last thing. One other potential advantage of looking more formally at treatability itself is that then the opposite of treatability becomes a useful measure that we can use. So then untreatability can be used as potentially a proxy for mortality or for an intermediate indicator to be able to better model mortality. Thanks very much.
Thank you, Chantal, for the great presentation. We move on to the next speaker, Shengxia Song from the FAO, Food and Agriculture Organization. She's coordinator, unit head, and FAO lead technical officer for the AMR quadripartite collaboration. We are very much looking forward to your talk. Thank you very much for coming.
Thank you very much, Professor Roth. Very good afternoon, colleagues. I'll be very happy to be here to provide an overview of the work AMR in agri-food system. I will begin with why. Why to address AMR in agri-food system is so important. So here there are some figures. Antimicrobials have been used in agriculture production for decades. It is so important to protect animal health and welfare. But the problem is misuse and overuse. For example, the growth promoters. So then, from the very recent report led by FAO, we see if the current trends ongoing, so by 2040, so we will see antimicrobial use will be increased by perhaps around 30%, 29.5. In another way around, if we have one health intervention, so we will see probably reduce AMU by 56.8% by 2040. So another report jointly by World Bank and WOHA almost have the similar result. So you see, if no intervention at a global, regional, and national response, so we will see the AMR will cost about $950 billion in livestock production losses. And then if we achieve 30% reduction in the next 5 years, and then the increased global GDP is about $120 billion. So this is showing a big picture why we need work on AMR in agri-food system. We know we are talking about to implement UNGA 2024 today. So this is a critical, important opportunity to really reflect the importance of the agri-food system. So there are 6 actions in this work, UNGA declaration. They are all relevant. to the agri-food system. Here I just put in here on agriculture and animal health and also environment. This is most relevant part. In the agriculture animal health, there are references including reducing the need of antimicrobials, renofarm. I will talk about this later, and also to strengthening animal health system, production health system, and also highlight the importance biosecurity vaccination strategy. So in the environment, in the agriculture, it's linking to soil, water health, it's linking to the forestry health, crops, aquaculture, and the terrestrial. So FAO has been working on AMR for almost a decade, since 2015. So we, under FAO Action Plan, we already supported more than 70 countries. We developed a set of tools, including to support lab and surveillance. It's already applied of more than 300 labs. And we now established 10 FAO AMR reference centers to provide support to FAO members. And we have the progressive pathway to support the members to evaluate the implementation of their national action plans. And also we have the legal framework tool. This is already moving from FAO to the quadripartite One Health tool. So this is a 10-year initiative we launched last year to support members. So to address AMR in an agri-food system, to really address the root cause, overuse and misuse. So we are aiming to support 100 countries, basically LMIC countries, but we also welcome high-income countries to share your experiences within this initiative. And we want to train 50% of workforce covering from animal plant health workers and professionals at the to support production level. 80% participating countries contribute to data. It's FAO in-farm system. So at this moment, we already received 69 countries registered to reduce the use at the farm level, because this is really an initiative focusing to support farmers. They are the end users for antimicrobials. And then we received another around 80 organizations, including civil society, academia, and also resource partners to join this initiative. So then basically how we are going to organize in this initiative, as just mentioned, we will focus on farm level. We are supporting to work with the governments and to organize activities in this five goods: good health services, including both animal health, plant health, good production practice, so including husbandry, including agriculture practices, good alternatives. If we suggest farmers to reduce, and we need to offer the solution. So otherwise, because we want to support, reduce, but not compromise their productivity. So then good incentives and how to motivate farmers to join this initiative. And a good connection, meaning we want to link these farmers with any other stakeholders along the value chain, including the manufacturer, feed industry, and and also the market consumers. So, and then another initiative is a surveillance initiative. Which is a part of the global integrated surveillance alongside with GLAS and animals. So this is in-farm, and we are, I would say, as a little younger brother compared with GLAS and animals. We just started, was first call last year, but we received very good participation as a first call. And 50 countries already participate, and we received 28 countries provide the real data. Now we try to do the first data analysis this year, and then we will launch the second call. So in a nutshell, emergence of AMR can happen in every sector, can spread, affect other sectors. Antimicrobials are largely used in food and agricultural production, and strengthening prevention, improving animal health and welfare, promoting good practices, and also alternatives to AMU, sustained value chains. Those are the key to curb AMR in an agri-food system. Data collection and analysis are the basis of monitoring the effectiveness of the interventions, and the scientific-based evidence is consistent need. And with agri-food sectors, improve the knowledge, test new solutions for staying ahead of drug resistance. So, and inform, develop, and effective policies, practices are really essential. So multi-sector collaboration through One Health approach, it is essential. And then quadripartite joint secretariat is really playing a very important role in advancing this effort. Thank you very much.
Thank you so much for your presentation. And we're coming to the last perspective, and this last perspective will go directly to the very core of what we would like to discuss later on, to the implementation of measures, to setting targets at the country level. And I'm very happy that we have Tachi Okwo with us. She is the head of Department of Disease and Prevention, Health Promotion, chair of the Nigeria Antimicrobial Resistance Coordination Committee. I'm very happy that you're here, and we are looking forward to your presentation.
Thank you very much. So the United Nations General Assembly Political Declaration has set targets. It has told countries what to do. And we at the country level, we're asking ourselves, what does this commitment mean? What actions do we have to take? And we are looking at them from a perspective where we realize that this doesn't happen in the ideal world. It happens where we need to factor in our health system constraints, our health system gaps, the data sparsity we have in surveillance, and what has been put on the table as targets for us. We have been asked to realize a 10% reduction in AMR deaths that are associated with AMR. We have also committed to 70% of the antibiotics being used in our countries coming from the access category, committed to being one of those 80% of countries that must be able to test for resistance in glass pathogens, and also be one of the 60% of countries that aim to have their national action plans fully funded. So at the national level, how do you interpret all these things and turn them into actions, into targets that will then feed into implementation? So I just want to share some of my thoughts around how we must bring context. Context is key if we are going to set realizable, feasible national targets. And the first question that comes to mind is, how would all this feed into our national action plans? What sort of actions will we take, and what sort of targets will lead us there? We ask ourselves, where do the AMR-related deaths occur? And who is dying and who is affected? We also have to set targets, getting data that must account for current access to antibiotics usage. What is the IPC compliance rate? But where is this data coming from? Are we just looking at those ones that are able to give us the data? That means we must put on our equity lens. What sort of indicators will we be looking out for? Are we just counting the ones that are able to give us the numbers? So it then means that in setting these targets, we must shine our light in those places that normally the light will not be shown. Because usually those are the places where the drivers of antimicrobial resistance are. We take an example now where we have many countries that are suffering from impact of climate change, desertification, wars, internally displaced people, fragile circumstances. It means that as a country, when we think about these targets, this 10% reduction, this access, we must begin to bring indicators that help us to drill deep and get data from places where we normally would not set targets for. So visibility is key, because if data only comes from places where the systems exist, we risk building a national strategy just on partial truth. We then move on after setting these targets. How will we implement? To implement, we must embed it within the development system. We must embed it within the system, the health system, the agri system, the food system. We can't just implement in isolation. We also must make sure that we have strategic information systems that are pragmatic. We must begin to integrate these systems and link them to antimicrobial resistance, infection prevention and control, antimicrobial stewardship and surveillance. We must build them into a system that allows us to then get into the One Health space and ensure that every player in that One Health space is contributing and implementing in a way that is coherent and that is tied into that vision, that agenda, that target that has been set as a country. We also must prioritize interventions where we know that change is possible and impactful. We can't, as a country, set targets we know that in the next 10 years we can't achieve. So in implementing, we must also make sure that we prioritize that. Accountability and inclusion is very, very key. In implementing, and this is where having a well-thought and well-structured national action plan, where every sector knows their responsibilities, we must be clear at the national level, and even for countries, for instance, Nigeria, we have a federal system, we must also even drill it down to the subnational, where everybody knows who is responsible for what, and where nobody is left out. We must not only focus on facilities that have laboratories, we must also ask the questions about, is there water in health facilities? Do we have water at our PHCs? This is the level to which we must begin to think about implementation. In the fragile spaces, in the internally displaced camps, we must go there and make sure that we're implementing. I've continued to mention that equity must be central, and this is where we have then to break down the information we are getting back, the way we are tracking and monitoring implementation. We must disaggregate our data, our AMR data, by region, by gender, by socioeconomic status. We have to start asking, how is water, sanitation, and hygiene infrastructure getting into the hard-to-reach places? We have to track access in rural, underserved, and displaced populations. We also have to set equity targets such as what percentage of IPC and WASH investments is getting to underserved facilities. Our AMR data from fragile and conflict settings, and same even for antibiotic access in informal sector. The farmer in the village, the primary healthcare center in the village, how are they accessing antimicrobial antibiotics? Finally, science is the North Star. Everything must be guided by science because it is science that then gives the policymakers the material they use to take decisions. So our evidence must guide our investments. Science must guide our prioritization. And science must also guide the evaluation of the actions we take at the national level. Modeling, yes, we must model life saved, but as we model, we must continue to push to begin to get more data in those unseen places, so that as we continue to model, people that look like them will be factored into future modelings. We must also look at life saves. How can all these then feed into scaling up so that at each iteration of our national action plan, at the midterm reviews, science will be helping us to fine-tune the strategies. And even if we need to recalibrate our targets, science will lead us to that. And I look forward to the conversations as we continue today. Thank you very much.
Thank you very much. And yeah, please give a big round of applause to the speakers. And I beg all the speakers to come up for the discussion and conversation on their perspective talks. Thank you very much. And I hope that Professor Putin is still around and can hear us and contribute to the conversation. So, thank you very much, first of all, for your perspective, your great presentations. I think we have learned that that there is already data that is informing political, or could inform political decision making. There is information that we have tools to reach the targets from the UNGA 2024 declaration. But I think that still there is, and you have highlighted this for the national country level, there still is a need that we have to adopt these different measures according to different settings. And I was wondering if one of you has an idea or a suggestion, what would be a good starting point to achieve or to initiate the way to obtain the relevant data that could inform politicians for implementing targeted measures for example, reducing the 10% mortality of AMR.
Okay.
So anyone?
I can start from where I left off. We'll have to, first of all, maybe look at our local burden, okay? Use local burden estimates. Even in spaces or in areas in countries that don't have perfect data, you can look retrospectively. You can look at your hospital data. You can use the global burden of AMR modeling. What is most critical is to set the baseline to even understand where is our starting point as a country and what are the things contributing to this. And when you have that, then you can begin to have conversations with your politicians. Is it the bloodstream infections that are contributing to that? Different bits, it's a composite. And you must understand the different parts. And in understanding the different parts, you also must know what will be the best way to communicate this to the politicians. And if you're able to communicate it to them, then you pull them to the table, they become part of the conversations, and you all continue to grow together. At least that's the experience at the national level for me.
Yeah. Mike, would you like to add to this?
I agree entirely. So I think Tosh is completely right. And I think you were saying this as well, that policymakers need to be convinced about the data. And they also need to be convinced that any intervention that is put into place, there is a monitoring and evaluation program that will allow a robust assessment of the success of that intervention or not, as the case may be. So that does require a better totality of assessment. But we also have to be aware that resources are very difficult and are going to get probably more difficult over that period of time. So I think that's where science is going to hopefully will start to come in, which is thinking through using existing data, as we were discussing, and using existing data better. And providing sort of relatively robust estimates and using data from different sources. And we need to take a sort of a bottom-up and a top-down approach, as Professor Hutton was talking about, which is trying to sort of therefore provide these overall estimates that countries feel are relatively robust and allow them and informs them to be able to start to move forward with some of the policy interventions. Thanks.
Yeah, thank you very much.
Can I add?
Yeah, of course, please.
I just want to add from agri-food system, I think data gap is remain a fundamental challenge in agri-food systems. But we see at a headquarter level, the four organizations work closely on integrated surveillance data. I think this is also very important to bring this to the ground level, to the field level. So, because many countries now, after UNGA, they start to update their national action plans. Surveillance is a very important pillar under their national action plans. We really would suggest at the national level, they can have a coordination part when they're talking about surveillance with the integrated surveillance part to really bring all the data together and to support, to inform policy, to inform practice.
Yeah, thank you very much. I think my next question would go directly into that direction. So you're addressing data gaps and barriers to implement measures countering AMR. So where would you see, and this question goes to all of you, would see the major gaps in our knowledge that would guide political decisions for implementing action on AMR? What would be the most pressing data gaps, or that you would see for moving forward and preventing us from moving forward?
I think that this...
Okay, I may interject. Let's allow Ivan Hutton to say something. He's been raising his hand. It's online.
No worry, thank you. I don't know if you can hear me in the room.
Yes, Ivan, we can.
Yes.
Excellent.
So I think in terms of a good place to get started in terms of data is basically the core indicator of prevention, which include IPC, WASH, and immunization. This is usually available. And I would say that the data on antimicrobial use and the data antimicrobial resistance. This is very basic. Countries are increasingly reporting their data through GLASS, and this is a good thing. And I would say that if you have these core indicators of prevention, and if you have a good understanding of your antimicrobial use and some understanding of your AMR data, this is a very good place to start. And I would fully agree with Zun Xia that we need the equivalent in the other sectors. So glass is in the human health sector, but we need to promote integrated surveillance to see what's happening in the other sectors. And this is also, by the way, the data gap often. So in response to your second question, thank you.
Yeah, thank you very much. Chantal, you want to add to this?
Just to add that in order to collect most of this data, we need to have functioning health information systems. So perhaps if you're asking for kind of a stepwise process, that could be the first step.
Yeah. And Joe, you also had a comment on the data gap.
One of the very cumbersome problems to overcome is that in many of these places, we do not know how many births occur or how many deaths occur to begin with. If a death occurs, we do not necessarily know what caused it, either syndromically or at the level of specific pathogens, and let alone at the level of a resistance profile and whether antibiotics were available that could have treated an infection. And I think that many of these things are daunting to put together at a national level if some kind of data system does not already exist. Even in high-income countries, there's very few places where we can quantify this reliably for all deaths, probably none. But there's been many successes with sentinel surveillance systems that, for instance, within confined populations, generate accurate estimates of mortality, sentinel networks of hospitals that can accurately surveil causes of death, and sentinel laboratory networks that can address the microbiological side of this. And I think that that is likely a model that will have promise going forward, at least with setting up something that is measurable so that 5 or 10 years down the line, we're not trying to model something that we were never situated to observe.
Yeah, thank you very much. I think that is a very important notion that these data collection systems need to improve. And how would you judge the current situation? You already indicated that there is probably a lack of interconnection between different silos, the veterinary system, the human sector. What would you suggest to improve this, or are there initiatives that would directly address this problem?
Yeah, I think because today we are talking about the link with science and policy, I think we should also have a look from a research side. For example, the One Health research agenda is published. In this publication, linking with policy and linking with data, this linking with evidence. So I think this can provide a very good guidance to all the sectors. And when you are coming up with data, when you want to address the challenge in this sector, so linkings from research and the policy side, because research can facilitate good evidence, good data, and then inform policy. So I would suggest our colleagues to have a look, because we have a very good already publication on this One Health agenda, research agenda. That really can bridge between science and policy.
Yeah. Thank you. Do you have any additions to this aspect of co-integrating data systems and generating the necessary evidence, surveillance evidence for antimicrobial resistance surveillance? Chantal?
Just a quick thing about, we tend to use the word integration very often, like to integrate the data across the different sectors, or integrate across One Health areas. And I know that the quadripartite is making like huge strides and really trying to explore what this should mean. But I think we need to be a little bit careful, because we use it so much that we can also be putting countries off, and because it sounds incredibly complex to integrate across all these sectors, when in fact what we need is something that where they can speak to each other without necessarily fully integrated. And I just reviewed a very interesting PhD actually that looked at this question of how much integration do you really need to do to be functional to the level that we need to be functional. And the student found that you need to have a board at the top with individuals from all sectors, and you need to have a common data set. You need to share the same data set. and that those are the two really principal pieces you need to have in place to be functioning. So I just wanted to say that, when we talk about integration, we don't necessarily mean something that's ultra complex and fully coordinated across different departments, etc. It can perhaps just be those two things to make it work.
That's good to know, actually. So probably the complexity is not that big. And probably then complexity becomes also explainable to political decision makers. And you put up this idea to reframe the AMR problem, which I think is an interesting approach for making it more accessible for those who are not into the AMR science. I was wondering how the others would comment on this idea of reframing AMR into treatability or not treatable. Would that help in the sense on those topics that you have been discussing?
I think I think we need to have better sort of estimates really about sort of antibiotic modifiable mortality, which is what we're really discussing here, which is around sort of, and I think that's actually quite complicated. And is an area that I think needs to be relatively we need to get better idea, particularly in resource poor settings where there are some major problems, of course, with with all sorts of support systems and also staffing and elsewhere. What is a realistic expectation about our sort of antibiotic modifiable mortality as well. But I think I just also wanted to come back to the common data systems, because I think that is in fact a way in which we can start to work across the across the One Health already. And it's not only about, obviously there is the ATC codes for antibiotics that actually are existing across that, but I think it's all about how we start to use data systems and actually integrate data systems. Nigeria has excellent data systems, already as well, and then trying to use as countries start to now there is in many countries, of course, there is now more digitization of data systems, and I think we should see this as an opportunity moving forward of trying to tackle digitization and say that if we can get some sort of common data standards across the quadripartite and actually think through much of those, then I think that will help a lot in terms of trying to make our data acquisition as most cost efficient as possible, because whatever we try and do with set up with surveillance, it's got to be the most cost-efficient way of trying to do the surveillance in the future with the resources that we're going to be facing, in the future. Thanks.
And that brings me to another topic, and I think that if you're talking about like resources, of course we have to consider the resource limitations present in some places, of course, and if resources are limited, you have to think about prioritizing specific measures. And so what is your take on this? So if you would not be able to do everything that you want to do, and from what you know, would expect that it has an effect on the AMR, how would you prioritize the implementation of these different measures that we have been discussing? So probably you can share your experience with this.
I'll give practical examples. So in some countries like Nigeria, you realize that there are some interventions that, and this is why it's good to build it into the system and understand the local circumstances. Let's take water, sanitation, and hygiene infrastructure for an example. You do know that while WASH will address antimicrobial resistance, it will also address other prevailing issues such as cholera. It will address a lot of childhood diarrheas and what have you. So it's easy to show that for this one investment, you will not only address a specific AMR issue, you will also address other health system issues. So from the perspective of cost effectiveness, cost efficiency, it's also easy to make that particular case. Another one is vaccination. It's also easy to look at it. We've seen the evidence that it does make a difference in antimicrobial resistance. It's also something that is easy to leverage resources already existing in other parts of the system. And down, I talk about not only the human health sector, but also in the animal health sector, it's easy to prioritize because we have the data to show that it does make a difference. From a practical perspective, it's something you can also communicate with the policymakers. It's also something that can show that for this one investment we are making, it will address a lot of issues we have in our system that we need to address. So these are some of the ways we prioritize these sort of interventions.
Yeah. Would you like to add?
Yes, I think we are kind of navigating in this kind of constraints funding. The question is, do we need to invest? I think it's not that. It should be, how do we invest wisely, strategically? So I fully agree with cost effective, but if we also think about the mechanism, it both efficient and also integration. So in the UNGA declaration, like MPTF, it's a focused multi-sectoral mechanism, funding mechanism, really playing a catalytic role. We should advocate. In another way around, we also think about how to integrate it with some bigger initiative, food security, climate change. So that will trigger more impact also. So then, for agri-food system, I'm already talking about reducing the need because we need to address an AMR from an upper stream. So we need to identify these key priorities jointly, the full organization, and also we should also identify key activities under each sector to really invest very cost efficiently and that has a higher impact.
Thank you. Mike.
And I think the discussion that Chantal was pointing out, and others, that most great majority of national action plans have not been implemented at the moment, because that is in large part a cost, a financial issue. So moving it to this next phase where we'll look at the Lancet AMR series, which sort of pointed out a whole range of interventions that one could do. You could do this, or you could do this, or you could do this, or you could do this. And I think for countries, I think the science needs to sort of think through better about trying to get the relative cost effectiveness of these different implementations at that country level. So taking into account your circumstances, taking into account your burden of disease, your use of antimicrobials, your use of vaccines, what is the relative cost effectiveness of these different implementation of different strategies? Because it's going to be hard for countries to do everything. At the moment, in many countries, the healthcare resources are being cut, not increased. And so therefore it's really going to be about prioritization of that, and therefore prioritization is relative cost effectiveness. And it may be that we also need to think about better ways of transmitting that information to the policymakers, and think through the frameworks by which that is presented to policymakers. Thanks.
Chantal, if I may ask you, as an economist, the economist here in this group, so we have to talk about like financing, the measures that need to be undertaken. Would you see the current way of reimbursement systems being like ready to take this task to somehow cross-finance all these measures that need to be undertaken right now, which will be, of course, also cost intense?
Okay, so, when we're talking about reimbursement systems, we'd be talking more about sort of richer countries that have functioning reimbursement systems. And there we need to be very conscious that we don't create perverse incentives within the system that would work against us in terms of AMR. So, for example, if a hospital has high levels of hospital-acquired infections, you want to make sure that you're not actually reimbursing more money to them in a way that actually is rewarding them, rather than trying to, disincentivize them from allowing infection to spread. So that's sort of the richer country context for reimbursement. And of course, though, in much of the world, reimbursement is not really a thing. Third-party payment is not in place in most of the countries where we really need to have the most efforts in terms of NAP implementation. So it's kind of two different issues.
Yeah. Okay. Thank you.
May I make a comment on prioritization and on financing?
Yes, please go ahead. Of course.
Yes, so in the health sector at least, we're really pushing for AMR to be mainstream into a PHC for UHC approach, primary healthcare for universal health coverage. So that's the objective of this document that we've put together on the person-centered approach. So one way to prioritize maybe when we look at the 13 core interventions is really to have a look in the health system. And the team from Anand Balachandran has done very carefully this work in a number of countries to see at the periphery what is implemented on the 13 intervention, and then see the difference between what's happening and what you would want to see happen, and then have an incremental approach to see what could be financed through the health system to make it happen. Then the second point, in terms of financing this intervention, it's also part of the 3-dimension of UHC. In UHC, we want to see more intervention, reaching more people with the least amount of financial hardship. So that's another reason to see the implementation of the AMR response as part and parcel of PHC for UHC. Thank you.
Thank you very much. Any comments on this? I think that's an important notion.
I think that one of the strengths of the UNGA declaration was that it was really very much a UHC-focused declaration, and focused really strongly on the Sustainable Development Goals. So, and that leads to a much more core understanding of essential healthcare services, essential medicines, and essential access as being the sort of pillars of as Ivan has been talking about. So that was one of the, if you like, one of the strengths of the language of the whole of UNGA declaration was it was a very strongly UHC focused declaration, as was expected, but it was also provides that core commitment. Thanks.
Yeah. I was wondering, Joe, so as you have been modeling all of the kinds of effects on measures onto the AMR burden, and would you say that we have sufficient evidence that would guide our decisions on implementing one or the other of these measures, or would you say that this is only a start, and that we need that the models are probably not the best at the moment? Would you see there, as we see that modeling is so important for guiding our decisions, would you say that we have to improve in this modeling area?
I'd say we do. This relates actually maybe even to the prioritization question earlier, where if you think of how this conversation has evolved over a decade, something like the O'Neill report in 2016 that lists between 7 and 15 priority intervention areas, perhaps, I don't even remember the number. Of the various interventions that people often discuss in association with AMR, those which have the best direct evidence of measurable impact are proximate clinical interventions, such as treatment with drug A or treatment with drug B, the effectiveness of a vaccine, the effectiveness of WASH, and other things that can be measured against a direct, often individual level or community level measure of acute infections prevented or mortality prevented. Many of the spaces of intervention that people even talk about for AMR along the lines of stewardship, One Health interventions, etc., although often prioritized, do not have these types of measures necessarily at the same level of trial evidence or well-conducted observational studies that quantify the expected impact that can be achieved in terms of preventable mortality with a given level of investment in their delivery. And so although these are often the first interventions that we look at priority setting stages and in national implementation plans, there is actually less quality evidence available right now to set expectations around what can be achieved with a given level of investment. And I think that remains a very important direction to go for modeling how many of the high priority interventions in national immunization plans can actually impact this space moving forward.
So actually, I would take this as a call for increasing the competence in the field of modeling and in the AMR space, so that on a country level you can have these kind of estimations to monitor and to estimate the effects of your interventions, right?
Or possibly a call to the scientists who are doing science at ESCMID to think about the policy implications of their science and design the policy implications into the science from the very beginning as well.
Yeah.
Maybe we wouldn't want to convey the impression that it's only modeling. Modeling is really a dialogue between preparing models that are basically what-if scenarios and the collection of empirical data. So I strongly agree with the statement that was made that it's all about strengthening data system, vital registrations, data on use, data on resistance, and put all these pieces together. And the strengths of the model is the use for policy that is based on a validation with a comparison with data from the real world. And it's this dialogue, this confrontation, and this constructive debate that will lead to progress in the estimation and therefore in the measurement and in the accountability.
Just a moment, Jorge. I just want to ask any of the panelists, or all of them, to speak in descending order of difficulty. Which of these three factors, how would you arrange them in terms of difficulty? One, generating the evidence. Second, translating evidence to simple language, like has been suggested, for action. And finally, getting governments to act. How will you rate these three factors in terms of difficulty in descending order?
Can you repeat that?
I thought that it would be probably good to, as we are moving to the end of the session, to also allow the audience to come to the microphone. Please introduce yourself, and we are happy to take any comments, questions. Please go ahead.
It's me. My name is Sue. My company name is Curatis. We operate out of Singapore and Germany. The question I have is related to supply chain. So I think we know that in cases of weak supply chains, for example, stock out short of supplies, over-reliance on broad-spectrum antibiotics, and, for example, poor quality of falsified medicines or antibiotics, all this can directly or indirectly lead to AMR. So I'm wondering for the panel to advise or give your insights on how national and global AMR strategies can further address the issue of supply chain. So this question or idea that I have came from the recent example that some countries need the Mpox vaccine, but they themselves can't easily access it until they are being donated. Thank you.
Would like to...
Do you want to do that? Or should
Yeah. I'll start with experience, and this is where having a well-structured governance mechanism where you have all the relevant ministries, departments, and agencies of government and all relevant stakeholders coming together as part of the governance mechanism of any AMR coordinating mechanism. So, for instance, in Nigeria, you have a National Drug Agency, the NAFDAC, you have the Pharmacy Council of Nigeria, and their job is when we identify some of these risk factors, and it's data that will lead you to that. We need to have the data that shows the level of substandard drugs. You need to have the data that shows you how many times hospitals have gone out of stock. And then they then take it as their own responsibility to go fix the things that are broken in that system. An example is that they realize that open drug markets are a problem in Nigeria. They then feed it into their own plan of work to begin to organize them into a more formalized setting. So my take on that would be that it still goes back to having an organized approach to addressing the antimicrobial resistance problem so that every responsible entity takes it up as their responsibility and then mainstreams it into their own line of work.
Sorry, I would.
Chantal, yeah.
briefly, I think we also now need to think better, I think, about what are the population health needs. If we manufacture as 300 antibiotics, and the essential medicines list has 41, which we think the WHO guidance covers, 90 to 95% of infections in the primary care and hospital sector. So I think there is a little bit. It's a very fragmented supply chain. It's a very complex supply chain we have, and I think it's a little bit more beholden on sort of kind of the communities to actually think through what are the critical medicines, and I think starting to think about sort of critical medicines, and then how one can put more robust supply chains around perhaps a smaller number of more critical medicines as well. Thanks.
Chantal, please.
Yeah, just to say that for sure a dysfunctional supply chain will completely wipe out any sort of stewardship structure that you put in place, right? If you don't have your first and second line available, and then suddenly you're just prescribing your fourth line, I mean, it works against us. So we really need to be working with the central medical stores of countries to really increase access at the periphery to the access categorized antibiotics. Just having a few lines available at the periphery would make a huge difference. And then, of course, there's the pharma companies who need to be registering their product in country, getting it to central medical stores. Right now, companies don't bother registering their product in most countries. Some of them only sell to the United States even. So we have to be thinking about how to encourage, not to say incentivize, but I would say even incentivize them to improve access to their products. So we should be looking at new ways to incentivize them.
There's another question. Microphone number 4, please.
Yeah, thank you so much. I'm called Moses Mukembo from Uganda, but also a Fleming Fund Fellow with the University of Edinburgh. My question goes to the UNGA, or the WHO director and so on. We've talked about the declaration about antimicrobial resistance, and they have showed us the different areas that were declared. Who is responsible for enforcing our countries, like Uganda, to ensure that these declarations are really implemented? Because why? When I remember the Abuja declaration, it was like 15% of the national budget should go to the health sector. But you find around 7-8% goes there. How sure am I that even this AMR issue, which you said is a silent killer, is going to be addressed in the national budget? In Africa, I think we understand the language of death. When COVID came and it was killing very many people, their money surfaced. When Ebola came, still money surfaced. Hypertension is killing people, diabetes is killing people, they said there is no money. AMR silently is also killing people, but the money is not yet seen. We are looking for funders. So I would really wish this UNGA declaration be enforced in our countries, most especially in Africa, to ensure that we do not die of this animal called antimicrobial resistance. Thank you. Who is responsible for enforcement?
Thank you very much for this comment.
The question was for WHO, but I think Junsha should also comment as another member of the quadripartite. In a political declaration, it's been actually approved by the United Nations General Assembly, which means that all the member states have actually pledged to make that happen. So nobody is in charge of enforcing, because every country has its own sovereignty. But what we, of course, encourage is a self-reporting of the progress. And this is what the TRACS progress, the TRACS system is all about, that is facilitated by WHO on behalf of the quadripartite, so that country can report their progress, and it's all available on the website of WHO. And we're hoping to build on this, and it's been already done, linked to more data of coverage in terms of prevention, in terms of resistance, in terms of antimicrobial use, and ultimately, when we make it happen with a collaborative, with the ultimate burden. Thank you.
Okay, thank you very much. I'm very sorry. I see that there are a lot of additional comments and questions from the audience. I would like to refer you to the reception at 6 o'clock, where there will be room for further discussions, also with our presenters here. And
yes, we should.
I will have to close the session right now. Thank you very much for providing your very valuable insights. And I think we have seen that that we are going forward on in tackling the problem, but there's still we need to find our way to implement the different measures on a country and national and but also global level. And yeah, I think that we will have to continue this discussion. Thank you very much for coming, and I'm inviting you to stay here for the next session, which will be directly after this one, where we will look at the implementation of measures. Thank you very much.